I will officially call the Finance Committee meeting together at 10:10. Thank y'all all for being here this morning. It's quite obvious that I am not the normal chairman, Mr. Steve Montgomery. Normally, also, Mr. Robert Early's here. I joke in saying this. I spoke with both of them. One is out of the state, and the current finance chair he's out of the country, let's say it that way. So y'all have me today. So again, I appreciate everyone being here. I've been advised there's no one signed in to address the committee, which will take us down to item number 3 on the agenda. Quorum has been established, and so item number 3, which will take a motion and some action. It's attached. The September 27th minutes are there. If there's any discussion, I'll entertain that. If not, I'll entertain a motion. I have a motion by Dr. Weber and a second by Dr. Schrader. So thank y'all very much. Since proved. CFO, and she's already moving to the table. Sharon, good morning.
Good morning.
Floor is all yours.
Thank you. I just have a couple of items to remind you of during the CFO report. The first one is that I will be presenting year-end to you today. So BKD, our external auditor, is on site this week, so they have already started our year-end audit. And then you guys will have the pleasure of Chris Clark presenting to you on December 15th at this meeting. So it's an early meeting because of the holidays. So to start the financials, we have, I'm going to cover the monthly statistics fairly quickly, and then I want to spend the bulk of my time really just focusing on year-end. And I have added a couple of extra slides that were not on your portal to kind of trend out some of our key statistics. So I'm going to spend a few extra minutes on that this morning. If you look at admissions, and this is all monthly statistics for right now, we did finish just slightly ahead of budget for the month of September. You can see our patient days were about 14% ahead of budget. And our length of stay for this month, if you'll notice the trend, the last couple of months, we've really brought the length of stay down. We ended the month at 4.8 days compared to about a 4.47 budgeted target for length of stay. So some of the changes that we've been doing have really impacted these last 2 months. For our outpatient areas, you can see we are running pretty much on budget for ED. They ended up about 2% ahead of their goal. Primary care and clinic, specialty clinic visits, you can see on the right-hand side of the page, finished strong as well. We were right on budget for primary care visits, and then you can see in specialty, we were about 7% over our budget for September. When you look at the lab cases at the top right of the page, you can see they've been over budget all year. This is one of those areas that have been consistently over their budget for the year, and we finished up about 9% ahead of September. And I'm glad to report when you look at the inpatient and the outpatient surgeries, they are both over budget for the month of September. This is the first month that our outpatient surgeries have met budget, and the second month you can see there in the trend for inpatient, we're over budget. Psych continues to be high in patient days. We were about 9% over for the month. Our clinic visits remain fairly constant, and you can see that our psych emergency visits down on the bottom left are also pretty consistent with the prior months. our financial metrics, days cash on hand, we're approaching some of the lower parts of the year. Remember, most of our revenue comes in January, February with the ad valorem taxes that are created once a year. And you can see that trend is continuing. We finished the year at 158 days of available cash. When you look at our total cash on hand, we're at about 208. Net AR days remain right around 50 at 51. And for our year end, we ended our FTE per adjusted patient day at favorable at 5.58. Our budget was created at a 5.8 FTE per patient day. Our JPS connection enrollment, it remained constant this month, just a slight growth. We ended the month at 39,361 enrollees. And then these statistics, these pages are not in your, the next 5 or 6 are not in your portal. But I kind of like to, we do this during the budget process where we try to trend out 3 years and see where volumes have taken us. But if you just look at patient admissions over the last 3 years, we had an 8% growth between 16 and 17 and an additional 5% growth this year. For our emergency department visits, we're at capacity and we have pretty much not seen any significant growth over the last 3 years. This year, we saw 115,588 in our emergency department. That averages out to 317 a day consistently. And some days there were a lot higher than that, but that is the overall average. So also looking at our clinic visits, the darker shade, the bottom portion of these charts represents the primary volume, and then the lighter shading at the top is our specialty. But looking at them overall, we had 590,000 clinic visits this year in the last 12 months. Most of them, again, our primary care is weighted a bit more heavily, but you can see the numbers there. That's a 6% increase. And although 6% doesn't seem like a whole lot, that was an additional 31,700 visits through our clinics. Surgeries, you can see that with some of the challenges that we've had with surgeries, we have seen a slight drop, but as I pointed out in the beginning of the presentation, we have seen recoveries this last quarter for some of those volumes, so I would not expect this trend to continue. It's actually kind of on the upswing now. But total surgeries were just over 14,000, and our outpatient, inpatient mix has remained constant, where outpatient has been about 57 to 58% of total surgeries the last 3 years. And our psych patient days, again, the big increase from 16 to 17 had to do with bringing on some additional psychiatric inpatient beds at Trinity Springs North, but we've also seen just over a 4% increase this year. I put the acclaim encounters in here. We're going to talk about acclaim here in a second, but you can see the tremendous growth. Remember that 16, not all providers had come on to acclaim. That was kind of their first partial year. In 17, you see the full impact of all of the providers that had traditionally either been with PG or UNT, and then you can see in 18, We have added several groups as well as expanded many of those specialty and primary care providers. And then from an FTE per APD, this 5.8, this is our budget for 18 that we just wrapped up. You can also see that even though our FTEs are growing at the bottom, based on our volumes that are coming through, that growth is due to adjusted patient day growth. So now we are, again, hopefully finalized with September 18. Again, we close our books within about 2 weeks of year end. The auditors are here currently working through some information. Kind of jumping to the bottom, year to date, we finalized the year at just over $1 million of operating margin. Bottom line of $13.2 million. I do want to preface that there are always some significant estimates that we have to utilize, especially when we're trying to close in 2 weeks. And I need to remind you that this year was kind of a complete refresh or renewal of the DSRIP program that we've been under for the last 6 or 7 years. The state changed some reporting before we had finalized budget. They did not get everything in line, so they've changed the reporting period, which always used to align very nicely with our year end of 9/30. They have changed that reporting period to kind of slide it down 1 quarter because of some of those delays that occurred this year, to where we're not going to be reporting final results until December 31st, or as of December 31st. So instead of settlement in November, where we know that it's gone through kind of the state HHSC approval process, that process isn't going to happen until February. So as we are presenting year-end audits to you in December, that piece has not been closed. So what we've done is we work very closely with our reporting department for DSRIP, and we have closed our books with the assumption, kind of to make it super easy, for those metrics that we measure, overall we've closed the books at about a 75% achievement level. So if you think about in prior years, we typically have been at closer to a 90% achievement, but this is a new, kind of a new program, new metrics. About half of the metrics have been existing, about half of the metrics are new, and we are developing reports to track those. So in my mind, that is a relatively conservative number with 75%. There will be subsequent information that we are going to get in the next few weeks where that number will be updated and the audit can be closed. So I guess with all of that being said, I do want to iterate to you, the $1 million that we have right now in operating margin is still being processed and vetted. And that is really the only area that we did not nail down, in my opinion, before the audit, was the DSRIP achievement. This year's DSRIP, again, is very different. There's about 4 categories. The first 3 are really kind of checking the box, did you report? And we've assumed 100% achievement on those criteria. The Category C criteria, which are all of our metrics, new and old combined, we again have achieved about, or we recorded about a 75% performance on that. So we will know more as December approaches, but we are working with BKD to make sure that they can audit those assumptions. So that's just the one major subsequent information area that we will be evaluating in the next few weeks. So we have closed the books, and if I can kind of get you to focus on the right-hand side of the page, we do have year-end entries. Charlie doesn't have you don't have your screen, do you?
No, I'm not there.
Okay.
I'm going to be blocking you.
You're fine. We have closed the books. Again, year-end entries occur. We have lots of actuarial reports that are run. We have physical inventories that we perform, and all of that happens once a year. So the month is a bit skewed with all of those additional entries. But again, year-to-date is easier to look at the end of the year. Net patient revenue is over about $18.4 million. We did have some volume increases from inpatient. We did have a shift from outpatient to inpatient, but the majority, almost $15 million of that, is because of the new UREP program that took effect after the 18 budget was approved, and I cannot wait until October where I don't have to actually point that out again. But that is the majority of the overage for net patient service revenue. You'll see that DISH is under all of our supplemental funding, DISH and the waiver programs, which includes UC and DISREP, is under $1.4 million. I've been telling you for quite a while that, we felt like we were going to lose some DISH, and we backed off that accrual, so it would be about $1.2 million under for the year. I wish I could tell you that I was that good, but that $1.4 million is comprised of 3 really large variances that just happens to be very close to my original DISH projection of $1.2 million under. So DISH did come in about $1.7 million under budget. Our UC that we've been talking about extensively over the last 6 months is about $6 million under budget, but we were able to pick up about $6 million from DISREP. And we're going to be talking a little bit about that, but again, some of that is the new metrics, the fact that a large portion of the metrics is just reporting. And so I just wanted to point out there were quite a few different variances that make up that $1.4 million under. If you drop down to expenses, our salaries were about $11.6 million over budget. That is mainly due to patient volume, as you could tell by the FTE per APD. That was favorable year to date. And our benefit structure, that is inflated because of the additional salaries, as well as a large overage in our health insurance experience this year for our employees. Purchase service is $20.6 million. Again, the largest part of that is due to the change from the offload process that we'd had in prior years to the UREP mechanism. And that had, the offload impact was about $10 million of additional expense, and then our UREP IGT was about another $9 million of expense. So those 2 factors and the change in the way that we pull down supplemental funding is impacting an offset here and here. For supplies, we have done a great job at expense control. For supplies, there are $2 and $3 million variances for some of our lab and chemicals and reagents that we continue to outsource. Our blood expense is down. IT and software is down. So it is a a large array of categories that are creating that savings for us. And depreciation really just as a result of timing of capital purchases. Other operating expenses, the largest category of savings there is our utilities. Both electric and telephone with some new contracts are down, which is what gets us to the $1 million compared to our $4 million budget for operations. Again, bottom line, as we close out the year, is at $13.3 million compared to a $14.6 million budget. Are there any questions on the medical center?
What are some of the new metrics for the district thing?
Let me see. I had a sheet of paper, and I don't know if I brought it up here with me or not. I didn't. Karen may have to come up and update you on some of those. But one of them was cancer screening for patients as they come through. I know some of the others are kind of a performance and wellness focus. There's some for diabetic management and how well that we talk to people about that as they're here in our center. I think there may be mammography screenings. So the whole impact of the DSRIP, at least in my short opinion, is, you know, it's really about almost a population wellness and how well are we touching people and how often and how consistently are we doing things that would prevent major disease or inpatient treatment down the road. So it's a lot of the metrics that we actually watch when we are looking in the quality committee. Many of those align very well. Okay. Mm-hmm. So when we look at a claim, again, we have closed their year. There are not any large estimates that I'm aware of from an audit perspective that would impact the numbers that we closed with. Our billed encounters for the month were about 2% down, so 6% for the year, if you recall. And then our net operating expense per encounter, you can see for the month of September, we were over, but we did close the year within 1% of our budgeted target of about $153 per encounter. So as you look at the volumes from a flexed standpoint, operating expenses were controlled. Steve, in one of our prior months, if you recall, I used to have a physician graph up here. This is now the payer mix graph. I made the provider graph larger, and Steve Montgomery had asked if maybe we could go ahead and put who's contracted and who's employed. So it's a busy graph to look at up here, but on your portal, it's readable. If you have any questions, we can drill down into that at some point. But just as a reminder, on this graph, there's 392 total employed providers. That includes physicians as well as extenders. We have 14 contract, and there are currently about 32 positions open in these various specialties.
In that, on that, it says other open 14. Is that your other specialties that's included in that?
Yeah, at some point, the specialty, the slice of the pie gets so small. So once it got to kind of a critical mass, we just collapsed it into all other.
All right,
So we specialists get a small piece of pie.
If you're not a big group. Yeah. Yeah. I think the surgeons would pop out, though, if that makes you feel any better, Dr. Weber. So for the month, again, I'm really just going to focus on the year-to-date here. you can see that we closed the year at 16.9 compared to a loss of 12.3 million budget, about $4.6 million off of budget. And there's really one large explanation for that, and that's, again, the changes that were made in the DSRIP program. When HHSC reviewed our proposed metrics, one of them was setting over in a claim. Historically, PG had one metric that they recognized DSRIP revenue from, and we pull that over to a claim for the last 2 years of the DSRIP, the 5th and 6th year for the original DSRIP program. But with a fresh look and advisement from HHSC, we went ahead and took this metric and combined it over onto the medical center side. So a claim, because it's a wholly owned and there's a host of issues that HHSC had a concern about, rather than try to follow down that road, we just went ahead and pulled DSRIP over. It's probably a better revenue and expense matching from the medical center side, but that is the one largest variance that we had experienced in a claim. You can see there's some large variances, but again, you have heard over and over about these other areas and how that is impacted by our recruitment efforts and our inability to fill every budgeted position. So it doesn't net out to, on the bottom line, it doesn't net out to too much because you have less revenue, you have less salaries and benefits, you also have less supplies. So, are there any questions on a claim?
Just a quick one. The contract labor, is that the local tenant or?
Most of that is, and we incurred quite a bit in the last half of the year with the onboarding of the surgical group. But yes, most of that is due to temporary locums that are used in certain specialties while we recruit and try to fill positions.
It seems like it's low cost, but it's also a $10 million opportunity loss.
I'm not sure I'm following you on that one.
Because we're spending $6 million less on contract labor and salary,
Uh-huh.
but we're also collecting $10 million less on the revenue.
So we don't fill every position. There's only a handful of positions that we fill with contract labor. So you can't really say, well, it only cost you $1.2 million to fill. That's probably only 10, 15 locum tenens positions against the 30 to 40 that we have open. So there are many specialties that they just work extra shifts and it shows up in the salary line item versus the contract labor line item. But I do see, if we filled every position with contract labor, yeah, that wouldn't make too much sense. It is, yeah, whether it's a nurse, whether it's a physician, any employee, correct. So that is the last of my prepared comments for today. We really, again, when you look at our overall budgeted net income or loss from a combined basis, we closed the year at about $3 million compared to a $2.5 million budgeted income. It was a wild year.
Yeah, when you look at $1 billion budget, you know, those numbers get, yeah.
So this is the second full year of a claim. We're really in about the third year. If you recall, 17 is when we started to convert from JPS PG over to a claim. And then at the very end of fiscal year 17, we brought on the UNT physicians that almost double the size of a claim. If you recall that, and it's really pointed out nicely in that graph that I showed on, the trend for total acclaim encounters. You can see the doubling of the physicians and then the slower growth this year.
Any other questions for Sharon?
I just have a quick comment.
Yes.
Sharon, I really appreciate the executive summary.
Yeah. So it's not-
I'm just wondering, is there a way to put that summary into a graph that we can see year over year with these same items? I mean, income from operations, and that,
Absolutely.
because I think that gives us a much faster look at, changes in reimbursements and whatever else, and we can pinpoint and identify them year over year. Just a suggestion, but I think it's
Let
great.
me play with that a little bit. It seems like every year in healthcare is like a new year in healthcare. So, but we can try to account for what's volume versus changes and, when you graph out, and I've done this over, the last 5 years of supplemental funding, the changes that have occurred in that are huge and alarming to us as an organization. So yeah, let me work on some trending graphs and see what I can come up with.
A good idea.
It's a good suggestion.
Any other questions for Sharon? If I could put a simplistic summary on what you said, we have closed out 9/30, which is our year end. There may be some adjustments based upon the district, the way the revenue and the way that's handled when BKD comes in, but that's probably the only areas that you see at the current time.
Yeah, and it's really more about the information that we're going to be gaining over the next couple of weeks. We closed 2 weeks ago.
Right.
And we still are working on reporting and how that gets done. Again, the formal reporting isn't due until the time period 12/31. So in January is when we're really going to be closing out all of those performance reports. It's complex to close the books at 9/30 because we are having to estimate what our performance will be
Right.
at 12/31 and get that onto
Right.
our books before we close.
Okay. Before we move along to the next item, which is really 5A, and Sharon is already at the table for any other, is there anything else discussions-wise that we need to do? Then we need to have a motion for acceptance of the financial. I have a motion by Mr. Wynn, a second. Oh, yes. Thank you, Roger. Thank you, Mr. Fisher. Second by Mr. Fisher. All those in favor say aye. Opposed, no. Thank you very much. Sharon, anything else that you need to?
No.
All right. Yeah, that's right. You're usually, I was kind of shocked. You're usually down there at the end. So Sharon, thank you so very, very much. I think the next item is the consider approval of the purchase agreement, item number 5B.
Yes.
Would you go ahead and take that also, please, ma'am?
So I'm presenting this to you because materials actually rolls up through the CFO office. And if you recall, about a couple of months ago, back in August, we got approval to replace our infusion pumps. It was a $3.8 million purchase. We've begun that. We went through an extensive look back. During that negotiation and RFP process, we also were negotiating the cost of the disposable supplies that are associated with that. And so as you look at your summary, we have been spending about $1.3 to $1.4 million a year on the kits that we are, the disposable IV kits that we use. During this negotiation, we were able to get much more favorable pricing. So you can see there's two unusual items in this summary. Number one is the amount of the savings year to year. We expect to save about $550,000 a year from our historical spend with this new pricing. It's not a utilization issue, and it's not a typo. And the other unusual thing is the length of the term of the contract is 7 years. That is the expected life of the pumps. So we wanted to make sure to lock that savings in for over the utilization of the new pumps. So I'm asking for approval today for a 7-year contract. Total value is just under $4 million for medical supplies.
And this, I'm sorry, go ahead, Dorothy.
Before we, I just have one question. When I looked at the contract, it had in there a comment that if you fail to meet your minimal annual purchase commitment, what is our chances of not meeting that? Because there's a recalculation if that doesn't happen.
Correct. So Carl is in the audience, and Carl's going to have to come up and answer that for you. I'm not sure what we negotiated, the minimums. Many of our purchase contracts have a minimum requirement, and we are very aware of those, and we try to make sure that those are set low enough to where those would never be triggered.
Carl, you may want to
Yeah.
just give us a brief. I think I had the same. We're approving a contract, just make sure there's no
7
issues.
years, yeah.
Yes. So Dorothy's question was based on the minimum spend. Do we feel like that that's a risk that we would not be hitting that minimum spend?
Not at all. In fact, it'll probably be over. When you continue to see the increases in volume that we have with the patients coming in and out, there's very little chance that it'll be
Yeah.
below the minimum.
Well, one of the other reason I asked that question is that in the future, we are going to be trying to keep folks out of the hospital. So one of the deals is reducing your admission. So just wanted to make sure that we were, if you were comfortable in saying that's not a chance that we're gonna not meet our minimum.
It's very small.
Because in 7 years, I do expect us to decrease some of it.
Right.
Well, with the volume growing in the county, we probably won't, but that is what they're projecting. Okay.
Yeah, many of our contracts, and Dorothy, we can bring that back to you. I'll send you an email later about what percentage of current utilization is that threshold set at, whether it's, 75%.
Okay.
But there's an increasing pressure to gain these really great prices, that we do have to have a minimum spend, and the companies go back and look to see, what have you spent with us before? The other issue is that in order for the warranties for these pumps to be in place, I believe that we're required to be utilizing their kit.
We did.
So, it's not as if we're gonna be out shopping, and yet another reason for us
Right.
to lock in the 7 year.
Yeah, I think Dorothy's observation was a correct one, at least appreciate the input. The other question, Dorothy, was it's a long contract, but we believe the life of these units are 7 years, or at least could be longer, but definitely would be utilizing them for the length of the 7 years, so, good. Any other questions?
Well, I do have a
Oh,
question.
gotcha.
Should we not have been hearing about this at the same time when we were talking about the pumps?
That's a good question, Dr. Weber. I don't have a good answer right now about why there may have been this couple of month differential. They are separate contracts, and we were anxious to try to get the pump order started. So, there were a few additional clauses in the purchase of the disposables contract that we were working through over the last 30 days.
I think it took a little bit longer for the disposable part too, so we could get the deeper discount.
Yeah.
I think it took us a little bit longer to do the negotiating. So that's probably why it was a little bit longer than or a little bit later than the pump contract.
But in just thinking about when we were talking about the pumps, I don't think there was any discussion at all that we would have to use their disposables.
That's not unusual.
I believe-
The fittings are different, that, I would say, not the majority, but that is not a unique situation to where a manufacturer would require you to use the attachables that they manufacture.
There was actually 3 other companies that bid on the disposables
Okay,
besides Alaris, BD.
okay, great. Well, thank you.
I hear 2 conversations here. I'll just, again, summarize. One is, it is a 7-year contract. It is, will we meet our minimums, because it does have those contract issues in here. I think Dr. Weber's question was, we approved a fairly large contract for the actual acquisition of the equipment. Maybe we should have heard about the additional dollars, but we're gonna need these disposables anyway. We're using them every day from somebody. I guess on the positive side, you use the purchase to negotiate the lower price. I like the fact we're saving $500,000 from a savings standpoint. But I think, Chuck, your question, what was the total hard cost it took to replace this piece of equipment and the stuff that supplies it, i.e. the disposables? You probably would have seen it all at one time. I hear we may not have known what the savings would have been at that initial time. Is that?
That's fine.
Okay. Good. A, we gotta have them. B, they go with the warranty. And C, it appears we're saving a substantial amount of money, so. But I'm certainly in other discussion. If not, I'd call for a motion. I have a motion,
Second.
Dr. Weber, second, Mr. Bose. All those in favor say aye.
Aye.
Those opposed. Thank y'all very much. Sharon, thank you. We'll now move to item number C. Mr. Skillens, Ron. Approval of the interlocal member participation agreement between My Texas Direct and Tarrant County Hospital District, JPS. Good morning.
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 What I have in front of you is a participation agreement for My Texas Direct. And to give a little context, and I went through some of this with some of you before, but My Texas Direct is a workers' compensation network that would allow JPS, if we are a member of this network, to give our employees greater options and choice as it relates to how they can get their care done if they're injured at work. So if you think about how an HMO works in many ways, this is similar to that from a workers' comp's perspective. And so the incremental costs to us to participate in this network is $20,000. It will be administered by York, which is our current third-party administrator for workers' comp, which, as many of you know, is self-insured. And so the reason why this is coming before you, even though the dollar amount is small, is that this agreement invokes an interlocal agreement that has to be approved by the My Texas Direct Board. And so in consultation with General Counsel, we felt it necessary to bring it to the JPS Board as well, irrespective of the dollar amount. And so our plan is to, should this be approved, to implement this in January of 19 and give our employees a greater choice in terms of how they get their care done. The challenge in many cases is having access to specialists that take workers' comp claims can be very challenging and can sometimes take a while for employees to work through that process and be seen. And so this will alleviate that problem for a relatively modest cost, but it also will, we're anticipating, excuse me, a savings in our workers' comp spend, which currently annualizes around $1.6 million that the district, from a self-insured standpoint, pays. We anticipate this first year of implementation to save around $150,000 and hope to build upon that in year 2. So I'm happy to take any questions.
The savings will come because the network is expanded, but is there a contract within that keeps your costs lower than what we have with our doctors that they're going to now?
Well, the savings would come from, of course, we're self-insured, so the savings will come from employees will be seen quicker by their specialists. They'll be working through their care plan quicker. And so what happens today is that oftentimes, because they have to wait for extended periods of time, our costs go up during that period of time, and increase physical therapy, increase other treatments and other kinds of things, and maybe other treatments that may not be directly related to the injury. And so when we had them being York to estimate what our savings would be, their estimation would be is that our $1.6 million that we currently are spending would be a number less than that because of the efficiencies in this system.
Is this gonna, in the future, may help us lower the short-term and long-term disability?
That's a good question. I think, you know, obviously it depends on the severity of the injury in terms of whether this evokes, you know, disability. But I think, you know, from a employee satisfaction standpoint, this has been kind of a thorn for a lot of employees in terms of, you know, and I'm not to say anything disparaging against our great occupational health clinic that and the work that they do, but just the volume and just the dispersion of Tarrant County, that this gives now employees an ability, if they live closer to a clinic, that they don't have to come to the occupational health clinic here at JPS, and they're covered as it relates to that.
Oh, I see. Does it include also mental health also as well, behavioral health type thing?
I'm not, I don't believe so unless it directly relates to, well, I can't answer that. If it directly relates to the injury, the work-related injury, I know one of the things similar to, you know, as we've talked to York about these claims, is similar, if you have a pre-existing kind of issue, and say it's a behavioral health issue, but let's say you had a slip and fall and you hurt your back or leg or whatever, then the workers' comp claim would be related to that specific injury, even and not necessarily related to the behavioral health issue that you may have had pre-existing, although you can still have that taken care of through your regular insurance. But this would be specifically for workers' comp.
And most of them are doctors and physical therapists, or do they have chiropractor included in there?
Oh, it's the full body of specialties, so all specialties are included, which makes this great from an employee standpoint because you have all the specialties are included. And our own Dr. Haynes will be a part of the My Texas Direct Network as well, so employees can continue to still go to Dr. Haynes to have care, but in addition to the others as well.
Ron, will you have some way of knowing, being able to do follow-up that shows that we really did reduce the times for the employee to get back to work, or the time they was waiting to go to a specialist, that we can
Absolutely.
see a reduction in that?
Absolutely, and actually, since my group will be kind of the administrator of this area, what we hope to do is come back to the board and show what you're talking about in terms of metrics on both cost savings as well as efficiencies.
All right.
Yeah, Ron, I think if you so note to make sure you periodically get that back to us. I kind of agree with Dorothy. I think,
Okay.
hear what you're saying. I think the fact that Dr. Haynes is part of it
Right.
is great. I mean, I think that we feel comfortable there.
Right.
Yeah, obviously, we want to make sure our employees are being seen on
Are
time
happy.
and it's working. And so maybe we approve this with the understanding after so many months, you
Right.
come back to us and at least kind of let us know that we're not running into issues.
Yeah.
The only thing just in reading here, and I know Robert will sign this based upon board's approval, but looking at the participation agreement, this is for municipalities. It's this 504 is for special. Is there any other members in this? Will this be our own specific 504 entity, or?
We will be members along with other members, and so the other members, for example, would be Dallas County, would be a member, Alief ISD, Parkland, Ector County, Keller ISD are all members of this network. And so, you know, therefore, you know, obviously our employees would be members should we join, but the opportunity, and as we discussed before, is that once we're ready, if we want to have additional of our specialists from JPS
Right.
to join this, those other employees could be seen.
I hear the board's discussion is that we seem favorable with a little, not skepticism, but with a little bit of making sure we kind of get back and know what we're getting, if it's working for our employees, is the most important thing. Okay. Any other, go ahead, DT, I'm
Will
sorry.
these providers have access to our EMR system also as well, so that they don't escape to the EMR system?
EMR.
For the providers.
Well, as a treating physician, they would, absolutely,
Okay.
yeah.
So we won't lose all the.
But we
stuff.
won't lose the autonomy, yeah, absolutely, yeah.
Any other conversation, Ron? DT, anything else? There's no other discussion, I'd entertain a motion. Mr. Nguyen on the approval, Mr. Bosa on the second. All those in favor say aye. Ron, thank you very, very
All right,
much.
thank you.
Ron, maybe you could provide the follow-up through the HR committee, because we look at benefits, yeah.
Oh, I know Ms. Peoples coming up. Good morning, Wanda. Item number D, and clinical review service agreement between Sound Physicians Advisory and the Tarrant County Hospital District. Good morning, Wanda.
Good morning.
Good morning.
This morning, I'm seeking approval for a service agreement between Sound and the hospital district. And this agreement will provide services for our UR review and our denials. We currently have a single physician who's performing that function. However, he can only devote about 14 to 16 hours a week to this function. By going with Sound Physicians, it gives us the opportunity to have 24/7 coverage. So when he's out on vacation, right now we don't have coverage. It also, the thing that I'm excited about this company has the ability, and they have like an education arm who can help educate our physicians so that they are documenting appropriately, and our coders to help us prevent having denials, or to make sure that we're covering medical necessity appropriately. So by going with this company, it gives us much greater coverage as well as additional services. So they also follow up with the physicians then, and serve they contact the physician if there is an issue, and work through it with them to try to prevent having those issues. So,
Will this group be doing mostly your utilization review for
Yeah.
admissions and
Yes.
stuff like
Right.
that? Yeah, okay, all right.
Is this overlapping with another group in the business office that does the CDI work?
well, we have CDI the staff that looks at that, but it's not overlapping with the physician component of this. Right now, like I said, we have a physician who does this role, but he would step out of this, and that, by using this company, it would give us more coverage to be able to do that.
I have another question for you.
Okay.
Are they doing it on-site, or are they doing it off-site?
I'm sorry, what?
Are they doing this
On-site.
work on-site
Off-site.
or off-site?
It's off-site, it's
On-site.
off-site.
Off-site.
But they would come on-site for education and things like that. They can do
Is it
that.
done
You're out of the-
onshore or offshore?
No, it's here. This is the same group that we have our hospitalists with, but this is a different arm of their company
Right, but
that would
the
provide
arm-
these services.
I just want to make sure that is it
No,
onshore?
they're here in the United States. Yes.
Okay, any other questions for Wanda?
At
Oh,
what point
sorry,
do
DJ.
we, because the cybersecurity and all that stuff is pretty strict, and getting stricter and stricter, at what point do we go through and look at to see if there's SOX 2 compliance and all that stuff? Because I don't think we ever look at that when we award them the contract, but it's getting pretty strict lately.
That would be a Melinda and David question. I'd have to reach out to them.
Melinda, David, and Ron.
He's asking about the cyber.
The cybersecurity question, I
Cybersecurity.
would think they would fall under any other
It would be the same as
contractual
everything
arrangement we
else
have,
we
where
do.
we send information outside the district. I mean, we check their cybersecurity
No,
and PT, is that what?
SOX 2 compliance and all
Yeah.
that stuff.
They gotta comply with all that. I think that's,
I think the question was, how do we look at that compliance?
yes.
And
What's our confirmation that they're in
how do we
compliance?
make sure it's happening? And who is responsible for doing that? Is that Ron's group, or is that Melinda's group? Somewhere, and they should have some accountability to look at the cyber stuff. Don't everybody jump up at once.
I think it's David's group. There is a whole
Okay,
department that
David
looks
isn't
at.
here,
Yeah,
okay,
David's
David.
not here, so
David,
we'll.
that's why no one's speaking up, I guess.
Hey, David.
Thank you, David.
Sorry,
Well, that's where you were hiding.
I
Come on
apologize.
out,
Our
David.
feed in there is about 15 to 20 seconds behind you guys, so I heard David Melinda, and I started coming out here. So if you could repeat the question, I'm sorry, Mr. White.
Just checking, because I don't know if they onshore, offshore. I don't think we know that.
As far as sound is concerned, so sound,
For this line of work.
right, for this line of work, they're onshore. And because when we send them the data to be able to access stuff coming back into JPS, we block all offshore.
Okay.
Right, so we only build tunnels for organizations that may be offshore. Like for instance, we did have a tunnel to Accenture for a little while, but that network was going from their offshore to their onshore, then back to us. For sound, they're keeping everything onshore for us.
And then since a lot of information, I guess, is there a plan for us to start looking at requiring them, give it enough time to be SOX 2 compliance and all that stuff?
We actually, when we go through vetting vendors, we go through the entire HIPAA risk assessment, NIST risk assessment, to be able to validate, if we're going to be sending data to them, they have to prove to us their compliance to that. So we send an entire document to them to say, if we're going to be sending data to you, how are you backing up data? How are you testing your security controls? How are you doing that? And so we make sure that we have that document to ensure that we're not sending something just that they may lose control over it.
I think we may want to start looking at, because a lot of our
Yeah.
system now looking at SOX 2
But
compliance.
yeah, the SOX 2 compliance is something that's near and dear to all of us right now. Yeah, that's a good
Okay.
point.
So
Sounds like-
they've given you that responsibility anyway.
Yes.
Okay, all right.
Yeah, it was not a request, it was a punt, yes, absolutely.
David, you can
All
go,
right.
you can go back to the closet. And
Yeah.
go back to wherever you're hiding back there with all the IT. I think we feel better when we talk about security and head of IT security walks out. That's pretty good that you're monitoring, but
Always in the security.
I appreciate that, Dave, thank you.
All right.
The good thing is, sound like we're all over it, as I anticipated we would be. DT, anything else?
I know, sir.
Good deal. Wanda, any other questions for Wanda? If not, we entertain a motion.
Move approval.
Mr. Bose? Second by Dr. Schrader. All those in favor say aye.
Aye.
Appreciate it very much. Number E, I think Kathleen's here for maintenance agreement between Varian Medical and the district.
Good morning, everyone.
Morning.
If you would think back a month ago when I brought a contract forward, which you graciously approved for the second linear accelerator for the oncology program, at that time, while we were negotiating that contract, we also were negotiating a parallel contract for point of service sale service coverage for when that unit was out of warranty. Now, if you would remember, we're going to install and open up hopefully in October of 2019. The second unit that we just purchased will be in warranty for 12 months. So we're bringing forward today a contract that would start in 2020. We're thinking that far ahead. That would run for proration for about 9 months during that or 6 months during that fiscal year, and then run for another about 4.5 years into 2025. So this is a contract that would run starting in 2020, $91,000 for the first 6 months of that time period, and then $218,000 roughly for the subsequent years for a 5-year term. So this will allow us to lock in today's prices for a service contract for a unit that will go into effect in April of 19, but the service contract goes in 2020. Does that make sense? This is the normal operational process that we're going to bring forward as we buy large units and large pieces of capital so that we can lock in prices at the current rate versus doing it in the later time period after warranty.
Some of my simplistic ways, this is an extended warranty.
You could look at it that way, yes.
Yeah, I mean, what did we spend on the piece of equipment? Do you remember?
Pardon?
What did we spend on the piece of equipment?
Yeah, close to $3 million.
3 million, I was thinking $3 or $4 million. Okay.
Yeah.
Right. Again, I kind of see this as extended warranties, kind of, I see this, so.
It's a critical piece of equipment.
Yes.
All right.
Have a motion by Mr. Fisher, second by Mr. Bose. All those in favor say aye.
I would say on this contract, the information that they sent to you was a revised template with no information in it.
Correct.
Okay? It was just, this is what we are going to do, and I'd like to know what they've actually done, okay? Because they
Correct.
just gave you a template, okay?
E and B, Dorothy, you talking about the, yes.
Correct.
Yeah,
Point made, good, okay.
okay.
Kathleen, thank you very much on that one. Which brings us to number F. Dr. Duncan, there she is. Good morning. Item number F, another interlocal cooperation agreement, school-based clinic, HEB. Good morning.
Good morning. I come before you seeking approval to continue the agreement between Tarrant County Hospital District and the Hearst Euless Bedford Independent School District to provide care for our school-aged children and their families. This is a 3-year contract agreement.
Any discussion?
Move approval.
Have a motion by Mr.
Second.
Nguyen, a second by Mr. Bose. All those in favor say aye.
Aye.
Thank you very much. I'll take this point in time, we're talking about the HEB School District. For many of those who attended, several of you did, the opening of the Northeast Tarrant County Medical Home. Had a tremendous turnout in that community, and I know, Roger, you were there, and DT, you were there, but again, that community really was excited about the opening of the new clinic. So, again, Kenneth, good morning. I think this
Hey,
may be
good
one of
morning.
your
How are
first
y'all?
presentations to the committee.
It is the first one, thank you.
Why don't you update everybody on exactly what your role is, but welcome aboard.
All right, well, thank you very much. So my name is Kenny Carr, and I'm the Senior Vice President for Network Operations. So it's the other side, the ancillary, as well as engineering and radiology, pharmacy, laboratory, food services. So
Good.
I partner with my friend Wanda a lot. So,
All right. Well, welcome.
all right, well, thank you.
All right.
Yes, sir, I did. I did.
Moving right along to the next item of business on this thing.
I'd like to offer it for consideration, the interlocal fuel agreement between Tarrant County and the Tarrant County Hospital District. This is an agreement that would allow us to purchase fuel at the current cost for the whole entire county during a catastrophic event. Hopefully, we never have to use it, but if we do, I'd like to be prepared.
Is this like strategic petroleum reserve type thing?
Yeah. Any questions, reference to this one? If not, I'd entertain a motion. Have a motion by Mr. Nguyen, second by Dr. Schrader. All those in favor say aye. Aye. Opposed? Thank you very much. Kenneth, I hope all your presentations for the years ahead turn out to be as easy as that one. I feel quite sure they will be. Dr. Elliott, good morning.
Good morning.
Item number 8, third agreement to the medical education affiliation agreement.
Great. Good morning, Mr. Chairman and members of the board. We're here seeking approval of the amendment to the medical education affiliation agreement between Integrative Emergency Services Physician Group, also known as IES, and the Tarrant County Hospital District. This is already approved in our budget, and this will help us to continue our residency education as we move forward.
Any discussion? I have a motion. I have a motion by Dr. Weber, second by Mr. Bose. I think, Chet, you need to, and please note that Dr. Schrader needs to abstain on this one. All those in favor say aye. Aye. Opposed, no. Dr. Elliott, thank you so very much.
Thank you so much, Mr. Chairman. Mr. Chairman, may I have a point of personal privilege to offer some thank yous on this? I just want to thank everyone that's been so wonderful in helping us do this, from our legal services and also working with IES closely. But in particular, I wanted to thank Scott Rule and Diana Singer,
All
our
right.
Director of Academic Affairs. Thank you.
Great. Thank you so much, and thank you for what you do, Dr. Elliott. Thank you.
Thank you.
Item number I. Oh,
Okay.
see you. Good morning.
Good morning. Is this on? Yeah. Good morning.
Good morning.
I'm coming today to ask for your approval for 2 contracts. The first contract, asking for your consideration and approval, is a agreement between the Tarrant County Hospital District and MHMR for countywide MHMR services. The cost of the contract to the district is $1.5 million and some change. This allows for us to assist in funding MHMR for agency operations that include funding for the Addiction Services Liberty House for inpatient and detox treatment, court liaison and aftercare services, adult mental health peer support. We help fund the Children's Service, Tarrant Youth Recovery Campus, adolescent crisis respite beds, and we also help fund the Intellectual and Developmental Disabilities Outpatient Program along with day treatment. This is a existing contract, and so we're asking for a renewal.
This is our annual contract
Yeah.
that we do each year. It's been through the county, it's been through
Yeah.
legal, it's been through everything, but if there's any questions, we certainly would entertain them at this time. If not, we'd entertain a motion for
Move
approval. I have a motion by Mrs. DeBose. I have a second by Dr. Weber. All those in favor say aye.
Aye.
Thank you.
Thank you so very, very much. I think we're going to have another annual renewal on item number J.
Yes, sir.
Thank you.
So again, asking for you to consider for approval the interlocal agreement between Tarrant County and the Tarrant County Hospital District for funding of specified county programs. The cost to the district is $15,029,914. This was included in the FY19 budget, and it is an increase of $866,000 over FY18. So the contract is to, for the district to pay and reimburse MHMR to provide mental health services in the county jails. And then the second part of the agreement is to fund public health services to the citizens of Tarrant County.
Again, it's our annual contract, and it is a budgeted item, so if there's any discussion, we'd entertain. If not, we'd entertain a motion. Have a motion by Dr. Schrader, second by Mr. Bose. All those in favor say aye. Opposed, no. Thank you so very much.
Thank you.
Alden, thank you very much. Which brings us down to item number 6 on the agenda. I've been advised by council there is no items for closed.
There's nothing for closed, but on the report related to the contracts, the actual report is on the board portal if you wanted to look at the actual lists for contracts under 200,000 that were reviewed in this period of time. For September of 2018, there were 30, and then there were, in the category between 200,000 and 500,000, there were 4 contracts. Those lists are on the portal if you'd like to look at them, and please contact me if you have any questions.
Okay. Amongst the board, is there any particular items that we need to further discuss here and/or in open? I mean, closed? Before we have a motion for adjournment, before we do, I just want to mention 2 things. You know I can't sit here and tell people how to vote. I know many of you may have saw. I just want to remind everyone that we have a very important bond election that's coming up here very quickly on November the 6th. You may have seen the full page in the Star-Telegram on Tuesday. So I want to mention that, and I want a little confirmation. It's my understanding when we spoke at the last board meeting, Dorothy, correct me, we asked that we get the HR committee diversity report that was previously given in HR. We'd like to get that on the next available board meeting, which we're going to try to get it on the November 8th meeting, and I'll get with Scott and them reference to that. So, because that was asked in the last board meeting. There being no additional anything to come before the board, I have a motion for adjournment. If there's no additional business, Dr. Hurd, thank you very much for being here this morning. Dr. Schrader, thank you. Then we will stand adjourned at 11:15. Thank you.